Welcome to this episode of The Ortho Show, brought to you by Next Science, the makers of Bactisure and pioneers in biofilm disruption. Their most recent innovation has been making a splash in and out of the operating room with multiple publications in the Journal of Arthroplasty and Joey journals, to name a few. In addition, Next Science are supporting one of the world's largest medical device, multi-center, randomized controlled trials by patient cohort, putting their money where their mouth is. We are, of course, talking about Xperience, an FDA-cleared, no-rinse irrigation solution intended for prophylactic use.
From medical media, this is The Ortho Show.
Hello world, Dr. Scott Sigman, your favorite opioid-sparing orthopedic surgeon, here for another special episode of the Ortho Show podcast. We're bringing on Ravi Bashyal, who's an orthopedic surgeon who specializes in knee and hip replacement. He's the vice chairman in the Department of Orthopedic Surgery for Endeavor Health in Chicago. He's an assistant clinical professor at the Chicago School of Medicine, director of outpatient hip and knee replacement for Endeavor, co-medical director, chief hip and knee consultant surgery for the NBA Retired Players Association as well. Ravi, what a pleasure it is to have you on the show.
Scott, the pleasure's all mine. Thank you for having me. Big time fan of this show. You're doing a great job bringing information to folks, and that's really important. So thanks for having me on, and I'm excited to talk this morning.
All right, so let's just talk a little bit about your history, because I think, you're incredibly well trained. You did your medical school, University of Pennsylvania, residency, one of the premier residencies at WashU in St. Louis, and then you did a fellowship at some small little hospital in Boston at Mass General, where you learned how to do extra joint replacements as well. So you bring a lot of experience to the table here on joint replacement.
Well, yeah, and thanks for having me on. This is really exciting. I've been in practice now about 13 years here in Chicago, and it's been a great journey, to be perfectly honest with you. I love my practice. I love caring for my patients. I love the work that I get to do with our system and with our external partners. I've had the opportunity to work with the NBA Retired Players Association, Hall of Fame Health, all through sort of this joint replacement lens. And it's been a great ride. And I'm really interested in getting to the next level with joint replacement. And, my thought process of getting to truly a zero rate of infection, which is really what my goal is, has really been consuming me for the past several years. We know how devastating infection can be. And I think there's some things that are going on now that can really help us to bring that down. And that's really been my recent focus.
Yeah, and that's great. But the good, there's no competition for orthopedics in Chicago, so it's just easy. You just hang up and everybody runs to you. No, but so I mean, there are things that you can really do to sort of help separate yourself, from the crowd and provide better outcomes for patients. And what is the one word that all surgeons really hate? And that word is infection, right? If I could go the rest of my career and not have a single additional infection, how happy would I be? So let's talk a little bit about that, right? So in joint replacement in particular, that is, a really concern. Even though it's a very small number, it's still significant if you take the global look at how many joint replacements are being done. So let's keep it simple for start. How does an infection for a joint replacement typically happen, in the operative setting?
Yeah, there's a couple of mechanisms that we know about. Obviously, the joint can be seated at the time of the operation. We follow sterile technique. We have laminar flow. We do everything we can to prevent an infection from happening. But obviously, there can still be some contamination during the case, and that can subsequently turn into an early infection. We know that joints can be seeded if somebody were to get a bloodborne infection that can go to your joint and seed the joint. And then probably a third mechanism is an outside in mechanism where there's no direct contamination at the time of surgery, but before the wound epithelializes over, if there's some contamination to the wound or contamination to the skin around the wound, potentially bacteria can get down into the wound and infect that total joint.
All right, so let's talk about some of these specifically. I think antibiotics are self-explanatory. We all give antibiotics prior to surgery. The idea is there's been evidence to show if there's antibiotics flowing in the bloodstream at the time of the incision, any of those bacteria that sort of flop in, we're going to hopefully be able to have go away. How about laminar flow, right? Laminar flow is a cool idea. How are we using laminar flow in the operating room?
Yeah, it's Shockingly variable, and that's one of the things that I found when it came to infection prevention. Other than skip guidelines and giving antibiotics before the start of the case, which I think happens pretty universally, at least in the United States. There's a lot of variability of how we deal with the rest. Laminar flow being one of them. In general, we use that through the whole case. It's running through the whole case, and the thought being that the direction of airflow will help to pull contaminant away from the wound and certainly not push it down into the wound. But again, great variability. Your facility may or may not have laminar flow. If you're an ASC, you probably don't have laminar flow. And even in big hospitals, there's wide ranges of how that's done, let alone the other strategies, including irrigation, which I know we're going to talk about to some extent.
For sure. And then there's space suits, right? I think my personal take is the space suit is probably more protective for the surgeon and the staff than it actually is to reduce infection in the OR. But
yeah, I think that's been shown is that, it makes us feel good. We feel like we're in a cool NIH, outbreak movie suit. And we like our helmets with our stickers on them and can decorate them. But ultimately, that's to protect us from debris and blood and bodily fluid more than really having a dramatic impact on contamination of the field.
And completely agree. And then obviously there's time of surgery, the more efficient surgeries. I think the shorter time the wound is open, the less chance there is for a bacteria to contaminate. And we're going to take a deep dive on irrigation too. But before we get to irrigation, just to, again, because we do have some, there'll be a bunch of listeners who are patients as well. How does an infection happen in the operating room, right? We do sterile technique. We've got all of these things that are going on. But where's that bacteria coming from that gets into the wound that potentially causes an infection?
Well, as and as most physicians know, bacteria are everywhere. This idea that if you were to, shower and clean yourself with HIPAA there's no bacteria on your skin is wild. And frankly, the best way to understand that probably is from the opposite, in that if we had no immune system, we would all perish instantly. Bacteria are always there, and they're always trying to get us. And it's impossible to create a truly purely sterile room. Any operating in the room in the world, no matter how clean it is, if you swab it, you will grow bacteria. So bacteria are ubiquitous. They are everywhere. We do everything we can to make that surgical field as sterile as we can. Prep solution, antibiotics as we mentioned, Ioban draping, sterile drapes. And we can certainly make those individual items sterile by basically sterilizing them in autoclave or gas, but those things would be toxic to a whole room. You can't autoclave a whole room. So while we try to preserve the sterility of the field, there are certainly bacteria all around us, and it's basically a race. It's a race to see if you can get the case done before something's able to pop in, or one might even argue, and there's some studies that have shown that there's always some bacteria around, and it's really a race to see whether either your eradication strategy, whether that be irrigation or antibiotics or a multitude of other things, or your own body, the host, is able to fight that off and kill it before it sets up, becomes a biofilm, and becomes a raging infection. And so we're always in a battle against bacteria. There is infection all around you, and it's even in a non-operating room setting, it's just a constant battle to stop that from hurting us.
So one of the things that we're really good at in medicine is creating antibiotic resistant bacteria. I mean, it has been it's been a warfare between bacteria and humans and all other species for that matter forever, right? And so we've had this strategy with antibiotics since Louis Pasteur that we can kill bacteria with antibiotics. The problem is they're smart. They evolve. And so having an antibiotic only sort of philosophy is really not, what's going to happen. It just can't. We have to come up with other strategies. So one of the things that you brought up, which is one of the hottest topics right now when it comes to prosthetic joint infection, is this thing called the biofilm, which is the superpower of the bacteria that creates this sort of window or this sort of film around itself so that the antibiotics can't get in. So give us an explanation of what biofilm is for our listeners.
Scott, have you seen the movie Terminator 2?
Of course.
Okay, so that's what biofilm is. So if we think about the scenes where the droid has been sort of melted down and then reforms into this super organism that you just can't destroy, that's sort of the quick and easy way that I think of biofilm. To give it a little bit more depth, when you have an individual bacterial cell, we call planktonic bacteria, that lives on its own, and it's a cell, and it can live in an environment. But when those bacterial cells kind of come together, they form a little community, and they actually form a superorganism where they form a complex around them that has certain defenses that prevent antibiotics from being able to touch them and attack them. So it's like a physical shield, but it's also a superorganism. It on its own behaves like an organism, which is why I like that Terminator analogy. You can try to, isolate these little bacteria here and there, and those you can kill with antibiotics. But once they form into this superstructure, this biofilm, they are very difficult to attack because there's a defense mechanism around them. And one of the misconceptions is that biofilm takes weeks or months to form, that it only happens in chronic situations. And that's frankly not true. We know that biofilm can start to form within minutes of these bacteria getting together.
All right, fantastic. So let's talk about, some other tools that we're going to be able to utilize to help to reduce infection. And I think, irrigation has been one of the classic things that we've been using in surgery forever. And there's a lot of different types of irrigation. The hot topic within AAHKS, which is the Association of Hip and Knee Surgeons, is all about this dilute betadine. What color is the T of the betadine that you're putting in, which helps to reduce the bacterial load or perhaps helps to reduce the biofilm. But tell us how the betadine is used first before we make a jump into the other irrigants that are available.
Sure. Craig Della Valle, a really great orthopedic surgeon, well published, a real leader in the field out of Rush in 2012. Published a paper that looked at the use of dilute betadine. So taking betadine solution, which we know is cytotoxic or kills cells.
Our cells too, right? Not just bacterial cells. It's going to kill our cells.
I use that word intentionally. It is very cytotoxic.
Yes.
But mixing that with some saline and then letting it soak in a wound for 3 minutes before they close the wounds. And they compared how those total joints did when they were just using saline versus when they used betadine. And what they found was that they had a baseline 1% infection rate in their control group before they started using betadine. And that went down to 0.15% in this relatively small, I believe it was about 600 patients experimental group. And that really took off. As you mentioned, and I think this is really relevant, at the beginning of our conversation, you said, if I could go my whole career with one more infection, I'd be a happy guy. And we weren't talking about cost. We weren't talking about reoperations, just even for the surgeon. The burden of dealing with an infection, the consequence of dealing with an infection on such an elective case is burdensome. So a lot of people migrated toward this, myself included. I was out of training by the time this came out, and this idea had been around. And so betadine sort of became a really cheap and easy way to try and combat infection. Now, in the years since then, I think we've learned that there's some downsides to it. You alluded to one of them, the cytotoxicity of it. And then more recently, there have been some guidelines from the FDA regarding the sterility of those products. But to your earlier point, the way in which they were being used was also widely variable. While Craig's paper did nicely describe his technique and how it was mixed, in general, when you would go to operating rooms, people would just kind of mix it on the back table, and I would say, well, how do you calculate this? And the most common answer was, we mix it until it looks like some version of iced tea. And sometimes they'd say sweet tea if we were in the South. Up north, they'd say Lipton. But that was the measure of how we were mixing.
That's classic orthopedics, right? Evidence-based medicine. We'll just take a look at it, mix it together
with our own twist. Right?
With our own twist. So I mean, look, there's no question. When it comes to these things, there has to be innovation. It can be adjacent innovation. It's one step, and then we move to a next step. So there's a new irrigant that you're using at this point right now called Xperience, which, we'd love to hear more about, because this is now sort of taking it to an entirely new level as to how this works. So first and foremost, describe this new irrigant Xperience that you're using at this point so our listeners will know about it.
Yeah, so this has really, for me, been a game changer. And I know that term gets thrown around on every single paper, podcast, whatever it might be. But this has been the single most transformative technology that I've seen in my experience. And I'll explain why. I use robotics. I used PSI for a long time. I'm into the technology space, but this has been transformative. And just as an aside, if we think about how we have evolved on everything else, the way we make the implants, the way we put them in, whether it be the approach or an enabling technology like a robot or a patient-specific guide to put it in, all of this stuff has made dramatic gains, huge investment, a lot of thought. Irrigation, we're kind of just doing it like we've been doing it since the 50s or 60s if you're using saline, which to me was wild. So Xperience to me was really, really interesting because it was a solution that was cytotoxic to bacteria, but not cytotoxic to the living cells of the body when they were inside. And beyond that, its unique makeup allowed us to attack biofilm, which we know comes up very, very quickly. So I'll talk very specifically to answer your question. the basic ingredients of Xperience, or XP as I like to call it, the letter X, the letter P, are citric acid, sodium citrate, and sodium lauryl sulfate. So those are a lot of like non-orthopedic words. So I'll try to make it simple for myself and for everyone else. The citric acid and the sodium citrate, that's like the salt. Okay, so the way that this works to kill those planktonic bacteria, those little bugs that are just sitting around by themselves, is that it creates an osmotic potential, which even for orthopedic surgeons, we probably remember this from chemistry class. If the environment outside of the cell is really, really salty, more salty than the inside of the cell, fluid will go out and that cell will shrink down. So that's how it works to kill the planktonic bacteria that are floating around. But as we alluded to earlier, if they're in this terminator superstructure, we can't even get to them to be able to create that osmotic gradient. And that's where this is really, really unique. So what's really in XP? What are the key ingredients? So there's citric acid and sodium citrate, which are salts, and then sodium lauryl sulfate, which is a surfactant, aka a soap. And so in general, these concepts have been around for a really, really long time. If you want to kill planktonic bacteria, those little guys that are just floating around, one way to do that is to create what we call an osmotic potential, which is a fancy way of saying if the outside is saltier than the inside, fluid will come out, or vice versa. So sounds kind of, very biochemistry-ish, but even orthopedic surgeons can understand this. So the citric acid and the sodium citrate, they work via that mechanism. They make the environment around these cells that are floating around saltier, so the fluid flows out of those cells, they shrink down, and they die. The sodium lauryl sulfate, the surfactant, helps to potentiate that. Surfactant binds to certain proteins on bacterial cell walls and kind of helps to open them up a little bit so that when you have that osmotic potential, that's really enhanced. So it kind of makes that process move along more efficiently, more quickly, and more powerfully.
So it can kill, so it actually is bactericidal, but
Yes.
yet not cytotoxic to our living cells. And now we got to get to the bacteria in the biofilm. So what's XP going to do for that?
Exactly. When you have living cells, they're able to control their osmotic gradient. So that's why those planktonic bacteria die in that hyperosmolar environment. So yeah, now you got this big bad biofilm. How are we going to get to it? Because the osmotic stuff doesn't work if you can't actually be touching those bacteria. The surfactant can't bind and break apart that cell wall unless you're actually touching it. And you've got Terminator around it. Well, it turns out the Terminator, okay, I'll go to another movie, has like one flaw, like the Death Star, okay? And this is interesting because I'm not super into all those movies other than Terminator 2, but it's coming to mind now. And that is that they're held together basically with an iron molecule that helps to bind that. And the citric acid, sort of the unique property of XP, helps to break that bond. So once that breaks that bond, it sort of puts all of the bacteria into solution where they are now subject to the attack from the surfactant and the salts. And so by breaking that down, you gain access to the bacteria.
All right, so this is the first time that I'm hearing this. I've been doing this for nearly 30 years at this point. I've never really heard of anybody being able to break down the biofilm to be able to get to these bacteria. So it's really working in two separate mechanisms. But when I think of irrigation, okay, here's what I think. I think it's a delay to my case, and I'm going to have to wash it out because it's probably doing something that I don't want my cells to be involved with. So explain that process of using this intraoperatively.
And for me, that was really the biggest aha moment compared to sort of more regularly commercially available irrigants that we have now. And to your prior point, there are things that can break down biofilm. They're just really, really caustic. Okay, we have Bactisure, which is a great product that it helps to really fight active purulent infections. And it has a acetic acid base, which can also fight this, but it's cytotoxic. So the citric acid is sort of a gentler way to do that, but still effective. But to answer your question about workflow, rinsing out, cytotoxicity, the beauty of this product to me is that it does not disrupt my workflow. Okay, betadine, any other adjuvant are truly adjuvants in general. Okay, I'm going to speak in a hip and knee world because that's all I do. And of course, I think that's the most important thing. And it's a typical orthopedic surgeon way to go, but let's just bear with it. Okay. When I do my case, I'm irrigating at multiple points during the case. When I'm reaming the acetabulum, well, before I smack that cup in, I'm going to have to rinse out the reamings just so I can see. There's blood. I want to wash things out. I do irrigation for visualization during the case, and then I use it for dilution at the end of the case. Well, what kind of clicked for me in my brain was because XP is not cytotoxic, because it's the same color as saline, it's just used in lieu of saline for me now. So I just hook up the XP to my pulse lavage. Okay. And by the way, if you use bulb, you can use it that way. However you use saline for visualization throughout your case, you can use XP. So if I'm doing a hip, we make our incision, I cut off the femoral head, I'm at the acetabulum. I ream it out, I got to rinse out those reamings. But now when I'm rinsing that out, I'm rinsing it out with XP. It is delivering my visualization. It's a liquid. It's moving all that stuff out of the way. I put the sucker in, the reamings are gone. But now that antimicrobial fluid is getting left behind. It's absorbed in the tissue. It's absorbed in the bone. So now I am making my antibiotic sort of impact at multiple time points throughout the case, from the start to the finish. You asked me about laminar flow earlier. It would be silly if we had laminar flow and we just turned it on at the end of the case. But that's kind of what we're doing with adjuvants. We're doing our case, and if you're fast, 30, 40 minutes, great. And then you're dumping something in and letting it sit. Better than doing nothing, but why not introduce that throughout the case? And because it's not cytotoxic, I don't have to do a secondary rinse to remove it. I don't leave a puddle of it sitting behind, okay? It's just absorbed into the tissues. I'm doing my normal workflow. It's sort of impregnating this antibiotic solution throughout. And then our study from JOA in 2021 shows that it actually persists for 5 hours. So I have a little bit of protection against one of those mechanisms of things coming in. So a long-winded answer, and I get a little excited about it. It's because there's no other way to do it. It's saline 2.0. Why would we be using $1 million robot and a C-arm and the most advanced technology to put in the hip, and then I wash it out with something that looks like sweet tea? It doesn't make any sense to me.
You're evangelical on the pulpit here, where we're getting a lot of hallelujahs, but I love your passion for this. I think it's really important. And I think that, look, at the end of the day, we're all trying to be as efficient as we can, right? So, conceptually, if you were irrigating with pulse lavage, and then you're going to put some betadine in, then you got to sit around for the betadine, then you got to wash out the betadine. This is actually just part of your flow. I love that. Saline 2.0. You're going to use your pulse lavage throughout that entire process, irrigating throughout the entire surgery. And then, and then how long is it going to last? It's about 5 hours or so that it will continue with its bactericidal effect?
Yeah, so I published a paper in JOA along with some of my colleagues, including Dave Stulberg, which showed that there's persistent kill for up to 5 hours. And Next Science has a lot of the lab data to suggest this as well, but we formally published it in JOA after a Hip Society meeting in 2020.
Fantastic. And how much does it cost per case? I think that's always one of our big issues, right?
Yeah, obviously there'll be different structures, but it's basically less than $200, and that's
$200. I'm like, if I'm the patient, I'm like, here is cash, put that stuff in me for $200 to be able to reduce the potential for infection. And if you take a look, if you do some basic math, this doesn't have to be the module 2 from the SATs last month, which I heard was really difficult. But literally, you've got, like, we're going to talk next about your cases in particular and what your history has been. But, you have 1,000 cases, let's say, that you're doing at $200, it's a couple $100,000. If you've got an infection rate anywhere from 0.5 to 1%, and the cost of a revision is $70,000. I mean, you start doing the math. If I'm the CEO of Blue Cross Blue Shield, I'm like, this is going to be done on every single one of my cases because I want to reduce the risk of infection. I mean, it makes sense.
It absolutely does. And what you're alluding to is sort of the cost of infection. And I use that word intentionally. There is a financial component to it, which is huge. And that's really relevant. Mike Reese, published a long time ago that the cost of a 2-stage MRSA infection in a total joint replacement is upwards of $100,000. Well, if you can prevent one of those, you just bought a year's worth of XP or whatever it might be, let alone the surgeon cost, right? Alluding to your comment, and I loved it because it was organic at the beginning. Infections, and I'm glad I haven't had one in a while, knock on Formica here, are devastating for us. They keep us up at night, and let alone the patient. And this is what I get at. I run our outpatient program, and I know the patient comes in, he or she signs a consent form. I could have a heart attack. I could have a stroke. I could die. But that's not what they're signing up for. They're signing up for, I got my knee, and oh yeah, I'm one of Dr. Bashyal's patients who was playing golf at 3 weeks. Look at me, and I'm showing off with my other buddies. That person gets an MRSA infection, you start having conversations like, I'm going to go in, I'm going to take everything out, I'm going to put in a spacer, and hopefully, by the way, you're going to get IV antibiotics for months. I'm going to come in and put in a revision knee, and if you can walk around the block without pain, home run, we win. That's not what they are signing up for emotionally.
Yeah, no, I completely agree. The hip and the knee is attached to a patient. There's emotional turmoil for us as surgeons to have a patient have a complication. We want every patient to do well. And then for the patients and the families to undergo a procedure that perhaps is a second procedure, it's months of their life, potentially out of work and doing all of those things. It can really be quite devastating. So, 1,000% here, whatever we can do.
Scott, we've all seen that graph that if you look at survivorship curves of prostate cancer, breast cancer, PJI or joint infection is on that list. It's
Yeah.
crazy. People don't
It's
think of it like that.
high rate of mortality as well. So yeah, I mean, there's just so many reasons to want to reduce the rate of infection. But all right, let's talk about something that is important, right? And your world, the AUKUS world, it's all about data, right? So share with us about some of your evidence-based medicine with your using Xperience irrigation for your patients at this time.
Yeah, really appreciate that. And this started out for me as sort of like, let's see how it goes. But as my quote anecdotal data for me, I was looking at as like, we got to start publishing this. So as I mentioned in 2021, put out a paper in JOA that looked at how this works in a lab, what it kills, and this sort of theoretical persistent 5-hour kill, and sort of in a lab setting proved that it works in a chemical manner. Okay. We then looked at our patients. I went all in on this on December 1st, 2021. I said, I'm using this on every single one of my cases. And we looked at 1 year of data from December 1st, 2021 to December 30th, 2022. So 13 months of data. And I compared that to my prior couple years of cases, over 800 cases. And here's the thing, everyone always says, but I don't really get a lot of infections. And we were one of those places. My infection rate was 0.5, 0.6%, pretty respectable, pretty good. And by the way, across a wide range of patients, we looked at our demographics, and you can look at the paper to see it, but we weren't cherry picking ASC only easy cases. I work at a big hospital. We take care of complex patients. Most of these are ASA 2, 3s, 4, things like that. Nonetheless, I went from a 0.5 infection rate to a 0% infection rate, 0 out of the next 471 consecutive cases. And this is a real 0. This is not, they had a superficial infection that we did a poly exchange and treated for antibiotics anyway. These are 0 infections. None of these patients had any sort of extended antibiotic therapy or a reoperation requiring that. We only had 1 return to the OR, which was for a superficial wound that opened. But again, this was not, we were calling it that, and then we treated them the same way. There was no poly exchange, anything like that, versus 7 returns to the operating room in the other group, including that 0.5 or 0.6 infection rate. The problem with this study, Scott, was that because our infection rate was so low, it was hard to show significance. So this study that I'm referring to has been published in JOE now, which you're familiar with, and shout out to that journal. They're doing a really great job of democratizing and bringing information to people quickly, which I think is really, really important, but in a peer-reviewed setting. So I really love that group and how they're doing it. So we said, we got to look at this more longitudinally. So I kept going with it. And so then we looked from December 2021 all the way to January 2024, just a few months ago. And we wanted to get sort of 6 months out from that. So this has just been presented at Hip Society, but we've now gone in that period 1,042 cases with a 0% infection rate with very good statistical significance. I think 0.006 statistical significance compared to our prior, again, relatively low rate, a lower rate of return to the operating room. And as a side note, this is 6 months out. So we have had no infections for at least 6 months out. And if you look at the patients from 2021, no one has still gotten an infection. So we're over. And every orthopedic surgeon gets nervous saying it, but I haven't had one. And today is, we're getting into the fall here, and we still haven't had one. So it's been great data, and now it's going to be published.
I love it. I mean, I'm just thinking of like Jim Nantz as he's quoting an NFL game for the game-winning field goal, saying that they've never had one. But look, over 1,000 patients with 0 infections, that, when you start seeing things that you haven't seen before in clinical practice, that's really when, you need to get excited. You need to be able to share this information. Big fans of The Godfather, Ira Kirschenbaum, will give him a shout out for Joey Journal. I know that Andrew Wickline, who's another one of our Ortho Show favorites, has also been using Xperience now with a lot of positive success. He's had a paper published as well. So literally, I mean, look, at the end of the day, we as surgeons, we never want to see another infection in our career if it's at all possible. So it's all hands on deck to try and figure this out. Now, for our listeners and for the surgeons that are out there, how are they going to find this product? Where is it available?
Yeah, so obviously it's approved in the United States, available across the country. You can find your local Next Science rep. Every region has a rep or a manager, and then the contact information is on the website. The name of the company is Next Science, that makes Xperience, and the product is Xperience without the letter E. They can also, there are also certain hospitals where it's being distributed by Zimmer Biomet. So those folks that will be near and dear to many recon surgeons, reach out to those folks as well, and they'll get you in touch with the right folks to get this in your hands.
Yeah, I mean, it's no great surprise. Ivan Tornos, another one of our great Ortho Show alumni. I'm not surprised at all that he and Zimmer Biomet are at the forefront of this innovation in this space as well. Listen, Robbie, this has been fantastic. You're so passionate about this. What I love about this episode in particular is that you're sharing your experience, but you're also sharing the evidence, right? As well as the practical nature of how this is really being used. I think the word game changer actually is very appropriate for this. And we can't thank you enough for taking the time to be able to share your experience with this irrigation product.
Yeah, it's my pleasure, Scott. Big time fan of the show, and it's really fun to get to be on here. So that's really cool. Thanks for having me on. Thanks for what you're doing in this space. You are, again, bringing information to the public and surgeons, which is really, really important in this day and age. Really excited about this product. And like I said, once the data started to show up, it really started to bother me, internally. That's where the passion comes from. I'm just like, how are we doing irrigation the same way we did 60 years ago? It makes no sense. Certainly the data is powerful, and getting to zero is really my goal. I know that's kind of a high bar and it's probably not possible to get to zero, but I will tell you 0.00004 or whatever the number is when you divide, if we were to get 1 out of 1,500, whatever that number is, that's pretty good too. And we are now at 1,500 at zero. So I'm not waiting for the next one, but even when that comes, that's going to be a really, really low number. Appreciate all the support from the Next Science team. They're really dedicated to this as well. They actually have the largest medical device study in Canada, because this is considered a medical device that they are running now, where they're going to have over 7,000, I think it's about 7,500 or 7,600 patients that are randomized to this, which will just further bolster our evidence. You mentioned Dr. Wickline, who does a great job with this. He, as a side note, whole bunch of other stuff with this, has found decreased rates of inflammation in knees when using this. So infection is our big bugaboo, but there may actually be some other benefits that we're looking at. I've done some preliminary studies looking at fixation in bone, which show promising results. And Boyle Chang out of Allegheny Health has been looking at bone cell health, which looks very encouraging with this product as well. So stay tuned. There's a long runway with this. Thanks again for the time, and looking forward to engaging more.
It is an absolute privilege as the host of the Ortho Show to be able to share these types of really amazing, innovative products. So we thank you so much. This is Dr. Scott Sigman, #FollowTheFro, host of the Ortho Show. Till next time.